So HER2 positive breast cancer, we know, is what, 15, 20% of all breast cancers? I don't know if this is, this is a small audience. A lot of people that have HER2 positive breast cancer, I will, one disclosure, I talk regularly. I'm on the faculty for Genentech, so I do talk a lot about HER2 positive breast cancer all the time. But I'm a breast oncologist, and I see lots of breast cancer. Even people that I have in the audience that do not have HER2 positive. And HER2 positive breast cancer is an intriguing specialty, and it's an intriguing conversation. It may be the one area of breast cancer that in select patients we may actually cure, and that's even metastatic disease. And we have plenty of time. We have an hour. If you don't understand what I said, or if it was too technical, put up your hand. If you have a question, let's make this interactive. It's a small enough audience. We don't need to. We certainly don't need to, talk and a few questions at the end. I'm going to put my cough drop in, which may be too big to talk.
It's too strong. It's really good.
I know. I'll use it afterwards. So we all know that breast cancer is actually many different diseases. And I think that's important. This actually came about, I'd say 20 years ago. Well, no, that's not true. It came back in the 60s. What was the first type of breast cancer everybody knows? HER2 positive. It was not even at that time on the radar. But it was the hormone receptors, right? And I can remember a time, and you all, I'm not old enough, but do you realize that many breast cancer patients back in the 60s were treated with estrogen? Older patients, though, we treat younger patients. So, and the idea being that breast cancer we've known is different. And one breast cancer, even if it's hormone positive, may not be similar to another breast cancer that is hormone positive. The majority, okay, let's see if I can get this. Right now. Oops, oh God, what did I do? All right, on this point. So about 70% of breast cancer is ER plus or minus PR positive. Another 15 to 20% is HER2 positive. That means that they test positive for amplification of the HER2 molecule. We'll talk about that in a little bit. And then kind of the bottom part is what we call the triple negative. And triple negative breast cancer has had a bad reputation. It deserves it. HER2 up until about the 2010, a little bit earlier, also had a very bad prognosis. So the types of breast cancer are important. Remember, HER2 is also different too. Your triple positive, your ER, PR, HER2 positive is very different than your HER2 positive, ER, PR negative, and there's even subtypes within that depending upon, molecular aberrations within the cancer itself. So it's important to remember that, ultimately, it's not going to be I have breast cancer. It's going to be I have a PI3 kinase normal, HER2 positive, et cetera, right? That's what you're going to be talking about. We're going to be talking about molecular profiling of cancers. There are cancers that act just like breast cancer. I can tell you that. And then there are other cancers that are very bizarre and don't act like they should. So we know that HER2 positivity can be what? Gastric cancer, esophageal, lung. Okay, so there's lots of different types of cancer that can show amplification. Now, they don't act the same way most of the time because we know we don't cure gastric cancer with HER2, anti-HER2 therapy, but we certainly can use it as a means of treatment. All right, so types of breast cancer. Now, most of you know about this. And the best person that used to talk about this, and I'm glad we got a tree there on the wall. If you think of the HER2 epidermal growth factor, it resides on the membrane, the outside of the tree, the leaves and the branches. That's kind of what the HER2 molecule is. It's on the outside of the cell membrane. Then you got the trunk going through the cell membrane. And the very important part is the root system, which is your tyrosine kinase system, and that's right below. The tyrosine kinase governs proliferation, how cells divide, how quickly they divide, and then the other part, of course, is cell survival or apoptosis. You've got to tell somebody it's going to die, right, before it dies, or at least you're supposed to. So you've got competing systems, and these systems are extremely intricate with numerous different enzymes and proteins within the system that you can target. So we know, look, for example, the PI3 kinase. If you have a normal PI3 kinase, you're more apt to respond to Herceptin than if you have an abnormal one. So, and this is, believe me, an oversimplification. So this is what we talk about. Now, HER2 doesn't have any ligands. A ligand is something that turns something on, stimulate. Okay? But if you think about it, a normal cell has maybe, 10, 20,000 HER2 molecules on it. A HER2 amplified cell will have a million. So what does that mean? It means it turns itself on. It doesn't need anybody to tell it. And HER2, when it turns itself on, it'll bind with everything around, okay, but it likes to bind with HER3. And the reason it likes to do that is the HER2 and HER3 turn on that tyrosine kinase activity, what we talked about, the proliferation and the cell survival. And that's very important. A lot of our drugs may target the branches of the links. That's Herceptin, pertuzumab, tucatinib, some of the newer drugs coming up. But a lot of the newer drugs are targeting this tyrosine kinase activity that's below the cell membrane. And some of them have a completely kind of a dual effect like Kadcyla or TDM1. And so we're just going to kind of touch on this a little bit. So, we don't have time to cover all of the HER2 therapy and every little intricate, but we can digress if some of you have questions as we go along. So it's extremely important to remember that the drugs that affect this HER2 system affect it in different ways and at different parts, outside the cell and then on the inside in particular with the tyrosine kinase. The tyrosine kinase molecules are little bitty ones where, Herceptin's a pretty big drug. And that also makes it important because a lot of these drugs don't get into the blood-brain barrier. We all know that many patients with HER2 positive breast cancer, if they live long enough, a good percent of them will develop CNS metastases. And so some of our therapy, and we all know this, it's hard to get into the brain. Even antibiotics, it's hard to get into the brain, let alone cancer chemotherapy. Okay, so milestones in HER2. Have any of you seen that? I think it was on Hallmark Channel about the development of HER2. I didn't see it, but my patients started to love it. And what's really fascinating is that, do you know that they almost didn't develop Herceptin? And the reason is why? Because they didn't know how to pick out those select patients. The good thing about it is that there were a couple of people that made phenomenal responses, and that's the only reason they kept on. I have heard that the City of Hope Cancer Center, that one of their major benefactors is that they're one of the original investors in Herceptin. They get lots. That's how they support their campus, which we kind of laugh at. So Herceptin was developed in the late 1990s, around 2000, for the treatment of metastatic breast cancer. And it completely revolutionized how we treat HER2 positive. Before, if you were HER2 positive, you said to the patient, this is not good, but this is what we're going to treat you with, okay? But once you came around with these antibodies directed towards HER2, it changed everything. I actually have a patient who went on one of the early anti-HER2 protocols. She's a physician's wife, developed HER2 positive breast cancer, metastasized to the bone very extensively. She was also ER-positive, and she was looking for a way of treatment. Didn't really want to go back on chemotherapy, and entered into a Herceptin protocol up at Scott and White. It's the only place she could get in. She just got Herceptin. That's the only thing she got. And she told me that in the beginning, she couldn't back out of her driveway because she couldn't turn around. It hurt so bad. 20 years later, she just went off the drug. She's completely free of disease. She never wanted to go off until she saw her grandkids graduate from college. And finally, she says, if it's going to come, it's going to come. And she's been in remission now for a year and a half off of Herceptin. So here may be, and we hesitate, of course, to use the word cure, but maybe we are dealing with a patient that was cured and was on Herceptin for 20 years. Do I have other patients like her? Yes. Not as long, though. Almost all of them are one is about 11, one is about 7. And so the thing is that there are a group of patients at that tail of the curve that you see in all of these Herceptin trials, long-term remissions. So very, very interesting. Let me go back. Okay. Sorry, guys. It's been a long morning with this cold. There's certainly other drugs. We know that for early stage breast cancer, about 2006, 2007, this was presented at the American Society of Clinical Oncology, and literally within 6 months, every oncologist that treated breast cancer was using this across the United States as adjuvant. Everybody know what we mean by adjuvant. Okay, if you don't, stop me because that's very important. And so we started using it first, just high risk, no positive patients. Within a year, high risk, no negative patients. We know that lapatinib came along not too long after that. Lapatinib is a tyrosine kinase inhibitor. Remember how we kind of talked about that underneath the cell membrane? And then in 2012, pertuzumab came along with a protocol called the Cleopatra trial that for one of the few times in breast oncology, you can actually show a survival benefit. You probably have heard this. There's so much you can give to breast cancer patients, it's really hard to show survival benefit because you've got so much to give them. And, ultimately, most of the metastatic patients will die. But pertuzumab, along with Herceptin and chemotherapy, gave a significant survival advantage to patients treated first-line metastatic. This led, of course, every time something works in the metastatic setting, what do? Goes straight to adjuvant. And 2013, we saw not only pertuzumab in the neoadjuvant. Everybody know what I mean by neoadjuvant? That's before surgery. If not, stop me because that's important. And then we also had PDM1. I have a patient who was on lapatinib. She has biopsy-proven HER2 positive lung mets and was receiving lapatinib and Xeloda, which is kind of standard pre-TDM1 or Kadcyla. She relapsed just as it was approved, went on Kadcyla, and was in remission. And she developed very severe neurotoxicity, not peripheral, but couldn't taste anything, lost her smell. So we stopped, and she's been off the drug now for about a year and a half, going on 2 years, completely free of disease so far. So we're seeing interesting, things. And I've told her she's always a little strange, and each one of these days we need to write her up just because of the dysgeusia that because I've never seen that, nor has anybody in Texas Oncology or U.S. Oncology seen that type of side effect. And then, of course, pertuzumab for early-stage breast cancer, and then neratinib for extended breast cancer. Now, you all may not know this, but yesterday there was an anti-PD-L1 inhibitor just FDA approved for triple negative. Guess what? It's also in phase 2, 3 trials for HER2 positive. Exciting times for being a breast cancer oncologist. Okay, so everybody knows that you got to pick patients for this drug, because in the beginning, right, it almost didn't get selected because we didn't know how to pick those patients. So how do you say whether a patient is HER2 positive? There's a lot of pros and cons about how you should do HER2 testing. Believe it or not, the IHC gives you an idea about protein expression. That's really the end of the chain. You go DNA, RNA, protein expression. The problem with the IHC is what? You've got to handle the tissue right. The surgeon can't just flop it down on, the piece of, after he's done the biopsy. He's got to make sure the pathologist comes and gets it. You've got to get it in to fix it. You can't over-fixate it. You've got to cut it just right. And then you've got to have a pathologist that knows how to read this. This is not easy. Even in academic centers, it's not easy. So even though I like IHC, it's relatively cheap to do, and it's easy for people to at least, do it at their own laboratory, and you don't have to do a send-out and wait for 1 or 2 weeks. It has a lot of problems with it. It's usually graded 0 to 3+. 3+ is you've got HER2 amplification, probably, which we're going to talk about. You've got 1+, which maybe it's underfixed, or 2+, which is the equivocal one. So the problem with IHC is that you sometimes get those equivocal ones. And the next thing we look at are the fishes and sishes and shushes or whatever. And they're just different ways of looking at the protein and the chromosome. So what you're looking at is the actual HER2 copies, the gene itself, as opposed to how many chromosomes, 17. In the beginning, when they first started looking at this, you remember breast cancer is cancer, and it can have a lot of funny looking, cell counts. I mean, it may have an amplification of chromosome 17, which isn't necessarily HER2 amplification. So they were trying to correct for that. And they kind of overcorrected, and now they're kind of going back a little bit. The reverse transcriptase PCR testing is what we do when we do the Oncotype DX. Usually in HER2 positive patients, we don't do Oncotype DX because they're almost always high, and you're going to use HER2 therapy anyway, and is not recognized as a way of looking at HER2 positivity. So remember, the FISH, which almost most labs do, is a ratio of the HER2 gene copies over the chromosome 17 copies. And you can have too many or too few chromosome 17s. And now we know that it's not the whole chromosome 17. You can have parts of chromosome 17. And that's what's really screwed up everybody. Okay, so this is the new ASCO guidelines last 6 months. This is extremely important. We got our pathologists up to date. You read this article, but no, you need to really read this article. And they had to completely, this is published in ASCO in the last 6 months. And so you can really get a nice picture of it. But there's a couple of things. What do you notice? You notice right here, look, that there are patients that have a low ratio. Before we used to say if it was over 2, initially it was 2.2, then it went to 2. Oh, well, that's HER2 positive. Not always. You can actually have a ratio that is above 2, but you don't have a lot of signals, okay, of that HER2 molecule. And that's where this came in, is that you can have a low ratio, but if you have a lot of signals going on in that cell, that's probably a HER2 positive cell. So I will tell you that it's very complicated, because if you get an equivocal HER2, you're supposed to take the same area that you did the testing. You're supposed to do it again with another pathologist looking at it, and 2 people were supposed to judge it. Now, come on, guys, how many labs are going to do that? So most of the time, you're going to wind up sending the block out to a reference lab to do this. Fortunately, it is said that probably less than 15% are truly equivocal, and we're really having a hard time. If your lab, and I assume not all of you are from Austin, but if your lab does have a hard time with it, there are reference labs that know how to do this, and you should be able to say whether a person is HER2 positive or not. If your lab doesn't have the money to send it out, your patient doesn't have the money. Oftentimes we'll treat a patient as HER2 positive the best we can. But this is, I'm sure most of you in this room know, this is a toxic program that we need to be talking about. So that's important. Also, there are some subtypes. Lobular carcinoma should not be HER2 positive. Have a heterolobular that's HER2 positive? Yeah, but guess what? When we look back, it's a mixed tumor, right? So remember, not all breast cancer is pure. In fact, many breast cancers are not pure. They have a mixture of different things going on. And so when you have, by the way, some of these slides are from Genentech, and they let me borrow them. They're very nice. And they have really nice slides especially about the path. So when in doubt, have I had a patient that is 1 plus IHC, young woman, bad looking cancer? Did I order a FISH? Yeah, because you know what? I really wanted to make sure, because there's a small percent that you miss. So once in a while, if you have a patient that you think might be HER2 positive, we'll go ahead and order the complement. IHC, if it was that first, we'll order the FISH. If the FISH were done first, you can order the IHC, all right? And so there are times when you gotta think. There are tumors like the mucinous, tubular, and these are, of course, pure tumors. We're not talking about mixed. They shouldn't be HER2 positive, so something's wrong. If you get a HER2, maybe your lab's wrong, maybe it's a mixed tumor. I have a partner, bless his heart, who remembers a woman that they did testing on TrueCut biopsy, and it was HER2 negative, and yet when they did it on the actual excisional biopsy, it was HER2, just the opposite. And when they looked at it, what they found was there were parts of that cancer that were not HER2 positive, and other parts that were HER2. So this is important. You sit down with your pathologist, you tell them what's going on. I don't understand this, and most of them, will help you out on this. Okay, so adjuvant treatments, welcome, it's all right. So adjuvant treatment for HER2 positive breast cancer is evolving. Even as I speak, I'm telling you this is going to evolve. But I tell you today it's going to be different for you. I know this. Okay, but I'm going to try to at least tell you what we do now and what are some of the things that are kind of evolving, and in particular in the Catherine trial that was just published in journal. So adjuvant treatment for HER2 positive breast cancer. Now we've got to go back and we have to kind of put it in perspective. In 2006, 2007, these 4 trials were published, and they kind of said the same thing, that when you use Herceptin in HER2 positive patients, you decrease the chance of the disease coming back and also survival. Now, PARA was a European trial. We don't really use the Europeans don't even use it. So I don't want to talk about that because we don't use that in the United States, and actually the Europeans don't use it anymore. They kind of delayed the Herceptin layout, and you really don't want to do that. The longer you wait, the less benefit you're going to get. So the joint analysis, which came mainly from the East Coast, but pretty much all over, looked at mainly anthracycline. When I say anthracycline, I'm talking in the United States, Adria. In Canada, we're talking about epirubicin, but the anthracycline drugs, okay? Epirubicin, doxorubicin, adriamycin. And then the BCRG, which came out of California and Dennis Slayman's group, looked at anthracyclines, but they did for the first time. He said, what if we don't use an anthracycline? Well, now, why did everybody not want to use an anthracycline? Well, in the very beginning, when they gave Herceptin and anthracycline together, what did they see? Cardiac toxicity. And everybody, plus, what's also bad about anthracycline drugs? Believe me, I use these all the time, but what's bad about anthracycline drugs? Acute leukemia, 1%. Everybody in their practice has at least one. And there's nothing worse than having to treat a patient with acute leukemia who's gone through chemotherapy for breast cancer. And other things as well. Anthracycline certainly has bone marrow effects. So we know that anthracycline also has cardiac toxicity. Now, I'm going to go back to this slide, and we know that at the end of 10 years, there was about we'll say 25%, 1 out of 4 patients still relapsed. So we're doing better, but we're still not doing as well. For the patients in these trials that did not get Herceptin, add 10%. So it's not a cure-all, guys, but it's definitely decreasing the chance of recurrence, and we think the chance of recurrence is going to imply that we're going to get cured. So this
that's 1 in 4 relapse rate as compared to the control 1 in 3 without Herceptin. Yeah.
That's right. So you're not talking an absolute. We're not curing all HER2 positive, and we know that. And I will tell you, I'll talk to the investigators mainly from the joint analysis from the NSCDP, and what they've said is that for the HER2 positive ERPR negative patients, they kind of reach a plateau at about 7 years. They don't really see any relapses after that. Truthfully, even after 5 years. So many of my triple negative patients, my HER2 positive ERPR negative patients, okay, I will tell them 5 years is a pretty good number for you all. Not for the ERPR positive patients where we have something else, right? We got the HER2. I'm sorry, guys. But we got options though. We got new options though. So I mean, there's always good and bad news about everything, right? You have a triple negative breast cancer patient, you say you biologically have a bad cancer, but you're very sensitive to chemotherapy. Okay, you have a hormone positive breast cancer, you say you have a somewhat indolent, not all, but you have a somewhat indolent. We got lots of hormone treatments, okay? And these hormone treatments, you can live for many, many, many years, even with metastatic disease.
Okay, all I know when I was diagnosed, all I know was HER2 positive. I don't know if anything.
Your oncologist would tell you. Are you taking anti-hormone therapy, aromatase? So you're probably just HER2 positive, ERPR negative. because they almost always will add.
I mean, I was supposed to take it, but I just couldn't take it.
Okay, so then you were what we call the triple positive, then, meaning you had both the hormone receptors and the HER2 positive. I say this not knowing the case, but
Okay.
probably. Some women
And so
can't
what?
take it.
And so what that mean?
Well, all right, now think about this. Now, what makes a cancer grow, right? It's got to have some stimulus. Well, HER2 is a growth factor. Duh. So you've got a growth factor that is amplified, okay? It's pushing grow, okay? Estrogen, I have people that come in and they're estrogen positive, and they say, oh, does that mean I got it because I took estrogens or birth control? No, most breast cancer is estrogen positive. Remember, breast cancer comes from our milk ducts, and our milk ducts, they all have estrogen receptors in it. So, we all have estrogen receptors. It just means that our cancers, most cancers, when they develop from the milk ducts, will continue to make estrogen receptors, and they're very hormone sensitive. That's all that means.
It's positive, the positive.
Where you've got the hormone positive and HER2 positive. Okay?
How do you explain to someone who is HER2 positive to receive second Virginia?
We're going to be going into this in a little bit, and if you still have that question, we can go back to it in a minute, okay?
This might be like a way too technical question, and please tell me if it is, but what's the research interest in the clinical relevance when you're talking about the heterogeneity of the population of breast cancer cells? Like, how do we know that there aren't two separate populations, the HER2 and the ER?
They are.
They are?
Yes. In fact, think about this. One of the things about the CAFR trial, well, we haven't talked about it yet, but, okay, so we're talking about patients, neoadjuvant chemotherapy. They get chemotherapy, then they get their surgery, and they've got residual disease. Guess what? What is that residual disease? They haven't tested it yet. Could they be HER2 negative? Yes. How many times when a patient has, let's say, a metastatic cancer, why do you retest? Because there's about a 10-15% chance that it may have converted to HER2 positive or may have converted the other way. So the answer is you've got two things. When you've got a triple positive breast cancer, you've got HER2 driving that cell. And so if you take out the HER2, what happens to the ER receptors? And they become very enhanced, right? And so you've got to kind of get them both. And so patients that have the triple positive, you're going to give them all that anti-HER2 therapy and chemotherapy, and hopefully you're going to get rid of that part, but then you've got to work on the hormone receptor positive part. And that may mean, and it depends on, age and menstrual, you're going to maybe suppress the ovaries, you're going to give them an AI. You'd like to give them an AI if you can. AIs have side effects, you just got through saying. They're not fun drugs to take. We don't use fulvestrant anymore in the adjuvant. Well, we don't use it in the adjuvant setting, but this might be a good time for using fulvestrant in the adjuvant setting. Right? You didn't hear me say that's not a good
I need to ask a question.
Just say,
Okay, would it have been anything different for an oncologist to recommend for you to take if you wasn't able to take any of those 5 years?
there's all sorts of maneuvers, and I don't want to get into a personal case, but you can go to tamoxifen.
Couldn't do that.
It's hard if you can't do any of them, and it depends on what kind of side effects and things. And so what
Okay.
but I understand exactly what you're saying, and I do rarely have people that have a hard time with everything.
All three of my couldn't take.
Yeah, and it's tough when you can't do that.
That was worse on me than the chemo drugs itself.
I have had one patient say that, but most people I can usually get through it. But I understand.
Okay.
Yes, ma'am.
I just have a question about medicines. Just as you said, for ER positive, there's different drugs that you take for your whole life to keep you not producing hormones. For HER2 is more of just for 1 year you take Herceptin, and then that reduces your chance of recurrence. Is there anything else we can be doing?
Yes.
Okay.
Yes.
Because it's like it just ends. That's it. And then
Well,
we're like, well, we still have hormones.
It does. If you're hormone positive, of course, you're talking about 5, depending on what you're at, 5 to 10 years.
There's
Okay.
something we can keep doing. Whereas
And there's a drug called niraparib for high-risk patients that are ER positive. So the answer is there are some things that are being looked at they're looking at now in the adjuvant setting, again, going back to the metastatic. So what do we do in metastatic ER+ positive patients? They'll get an AI plus one of the CDK inhibitors. Well, they're looking at that now as part of the adjuvant. Those trials aren't available yet. I mean, I wish they were, but if you think about it, it should work. I mean, usually if it works in the metastatic setting, it's going to work. Is it going to just prolong the time of relapse? I don't know. You know, if you're 35, prolonging it 2 or 3 years, you know, that's not good enough. Now, if you're 75, maybe, you know, you'll die of something else before the cancer comes back. So you understand what we're trying to say. The idea is to prolong the relapse until you die of something else. Okay? I know that sounds, you know, but it's really kind of true. I will tell you, I'm just going to point out here that the 3-year relapse was about 12%, so about half this. Yes, ma'am, they go.
So that happened in my case where, and then from the fish they said I was HER2 positive.
Yes.
So I always took that to mean that maybe I was HER2 positive, but I didn't express it strongly because of the first test.
Could have been due to many things.
And that's what, so my interpretation of what you just said is that that's not the case. It could have just been.
Absolutely. If you leave it in the fixity too long, if you have it on the table before you put it in the fixity. You know, actually this is true of all testing. Okay? If you have a specimen that you remove from the body, and if you deprive it of its blood supply, those cells that are growing the quickest are going to die. Well, that may be the more important part of your cancer that you want to know about. So, but they've actually done studies looking at this, and the longer you have it sitting there, that the nurse forgot to pick it up and put it, you know, I mean, in the old days, you just kind of, in the OR, you just kind of plopped it in. No, they record everything now. They're supposed to record the time that the surgeon hands it to the nurse puts it in the fixative, and then how long it's in the fixative. Now, I can tell you, Austin has a sophisticated pathological community. El Paso, our hospitals follow this. We checked it, and believe me, you know, you cannot be approved as part of a breast cancer center unless you do this type of thing. Okay? So, you know, if we come from a small community, it's harder. But many labs then will do send-outs because this is above and beyond. I mean, for, you know, daily pathologists trying to do everything. Okay, so this is the Cleopatra trial that I mentioned. This is for metastatic breast cancer. And you can see there's pertuzumab. What they did is they had Taxotere Herceptin. These are patients' first line, metastatic, Taxotere Herceptin versus Taxotere Herceptin pertuzumab. And obviously, adding pertuzumab to this was important. Now, pertuzumab is kind of like Herceptin. It attacks HER2, but in a different area, and it prevents it from binding to its partner, HER3. So, if you think about it, if you're attacking it one direction and another direction and preventing the dimerization of that kind of HER2, HER3, it's kind of like a double whammy, and that actually is something that they confirmed. And when they came out with this, and then were able to show within a year overall survival benefit, which again, as I said, you just don't see this in breast cancer very often, it rapidly went into the neoadjuvant. This trial was extremely important before they went into the neoadjuvant trial. These are the pre-surgery trials where you have a breast cancer, you treat with chemotherapy, and then you do the surgery after, usually after chemotherapy. Yes, ma'am?
Why are these drugs only before surgery? Why can't they be given after surgery?
Well, they can now. Oh, that's the affinity trial, which we haven't talked about. You guys are good. The affinity trial, which at the time that this was published, the affinity trial was just about ready to be started. The affinity trial was the true adjuvant trial, which was looking at Herceptin versus, you know, plus or minus pertuzumab. Now, I'm going to tell you, tucatinib, you're going to start hearing about this drug. It's entering into phase 3 trials. Tucatinib is kind of like pertuzumab. It has a strict affinity to the HER2, and the combination of Herceptin and HER2, even in very heavily treated patients, is very intriguing. Okay, it's not FDA approved. But what's good about tucatinib, it's in the brain. Not curing, guys. Not curing, but it gets into the brain. Much better than lopatinib, which is the other drug that kind of gets into the brain. All right, so there were 3 smaller neoadjuvant. My secretary, bless her heart, she did this, and I meant to have another paragraph on this, but I didn't. So let me just tell you that based on 3 smaller neoadjuvant, this sounds not good if you don't take pictures of it. Based on what we just saw in the metastatic, and then based on, these 3 small neoadjuvant trials, which used anthracycline, so we already talked about what anthracyclines are, and then also used the Taxotere carbo program, which came out of the early, Dennis Slayman trial, was the FDA, for the first time ever, said, we're going to approve this drug based on, let you give it neoadjuvant, but because we also know that you got an adjuvant trial coming up. And at the time, the affinity trial, which was the adjuvant trial, was ongoing. So they knew they were going to get the answer. And so with this, they were able to approve the use of the neoadjuvant pertuzumab Herceptin, and you could use kind of they have like 3 chemotherapy programs. Everybody in the Southwest used the TCHP, and everybody from the East Coast used AC. I'm sorry, I'm prejudiced. No, but that's okay. There's no right or wrong. They're just different sets of side effects and different things you need to look for. And there, it's maybe a 1% difference, but I'm, not totally convinced yet. Yes, ma'am.
I got TCPH chemo, and I'm just curious, how did they get the 6 rounds, what we've seen typical versus less or more?
Well, ask oncologists this, and they'll tell you it's always even numbers, right? I mean, like Hodgkin's disease, it's going to be 4, 6, 8, 10, odd numbers. And some of it is based on animal, but a lot of it is just, empiric. So the 6 cycles were empirically selected. Part of it is because of the toxicity of the drugs. Now, if you look at the metastatic trial, the Cleopatra trial, they gave patients fairly large doses of Taxotere. Now, for those of you that have not had Taxotere, that can be a tough drug to take. And they also found out that certain Asian populations didn't do well with Taxotere. Okay? And they had a lot more side effects, had to reduce the dose. And in fact, what a lot of us did that participated in the Cleopatra trial, we would get our patients into a really good remission and then go like 1, 2, 3 more cycles, and then we'd stop the Taxotere and just continue the anti-HER2 therapy. And that's been kind of what we've done with other patients with metastatic disease. And does it work? Yeah. I mean, there comes a time when you've got to stop this stuff. But there are patients that receive the Taxotere for years. So your question is, remember, you're dealing with adjuvant therapy. Okay? We're not dealing with metastatic therapy. You've got to stop at some point.
So you still have, I got my surgery, but I got 90% and 35% of everything. In that case, you can have the person continue chemo.
$1,000 question. That's Catherine.
Okay.
Whoops. Oh, God. All right. So what do we consider high-risk HER2-positive patients? Well, it's really, if you think about it, it's big tumors, right? Locally advanced tumor, in particular inflammatory breast cancer. The original definition used to say, 2 centimeters or more. These are T2 lesions. Okay, keep in mind how the pathologist measures. Is there a real big difference between 1.99 and 2? No. Okay. So no positive there is important. No positive is very important. Younger patients. I wish we had a good answer as to why younger people in age, the older I get, my younger patients now, that should be 50. But younger patients, usually the definition is around 35. However, I personally think anybody under 40, and sometimes even under 45, I think that's young. So these are, and then patients that are ERPR negative, HER2 positive, these are all what we consider high-risk patients. These are the ones that are going to relapse, most likely.
10%.
So in cases like you said, no,
And for some patients, like, you might not know, you have neoadjuvant chemo, you know, maybe it's clinically low negative, but you don't actually know.
Well, at the time of surgery, you're going to check.
Right, but that's after
But you are
doing
absolutely right, and you do as much as you can. The surgeons tell me that if it's clinically a negative exome, either through MRI, ultrasounds, or all of the above, they will not invade the exome. And part of it is because you can screw up in the post-surgery when you go back in, as long as they'll do the sentinel node at the second time. And if you're negative, you're negative. But yes, the answer is yes.
The
You are
assumption is
correct.
that it was always negative.
That's, they assume that. Could there be micrometastatic disease? Sure. But they got rid of it when it became a
I have a question as someone who also has a neo-positive HER2, but I'm actually curious because my primary cancer had HER2 positive, came out with fish, that it was positive, but no one told me about what's in my lymph nodes because actually I had extramolecular extension, 2 of them actually were actually packed with cancer. So why would they just test? Like, are they very?
They actually will do both. I know our pathologists will do both.
That's
the primary tumor, and we'll also do the nodes at the same time. And especially if there's any question about this being mixed. And have I seen things differ? Yeah, but that's pretty rare. But yeah, yes, it does happen. And then the mixed tumors guys, they don't know exactly.
Okay, when you have the inflammatory breast, I mean,
In inflammatory breast, in the very early trials, patients that had what we call unresectable disease, which is, these are T4. I know you guys, there's a lecture on inflammatory, I think we're competing with it, but inflammatory breast cancer is, believe it or not, is not a pathological diagnosis. Don't let people tell you that. If they say it, they're wrong. It is a clinical diagnosis, and it looks like an infection. Yes, it's true that if you take a biopsy, you're going to see cancer cells in the dermis, invaded. But it is a clinical diagnosis, always has been a clinical diagnosis, even though they're getting close to try to find markers that will say this is a marker for inflammatory breast cancer. So, yes, so the answer is, yes, they're trying to better define it. But what I was taught, of course, is that it's a clinical diagnosis, and it really is a clinical diagnosis. I get a lot of panic phone calls from non-cancer patients who want to see an oncologist because they get a little redness. They go on the internet, Dr. Google, the first picture he shows is inflammatory breast cancer. And I get people in my office in tears that they know they have inflammatory breast cancer. Well, it's a clinical diagnosis. It's not a little rash or something. So one has to be careful, and we frequently will get that asked.
When you're saying the high risk of HER2 positive patient, when you're saying it was likely to come back?
Well, just high risk. I mean, we know that if you're have negative lymph nodes, you're at less risk than positive lymph nodes, right? And if you can't talk about.
Okay.
I know. I wish we could, but we can't do second opinions because there's so much that goes into this. But the whole point is that these are just relative risks, right? These are all relative. There may be patients that when presented with this down say, I think I'm high risk. I want everything despite, right? Your recommendation. So, okay, now this is the affinity trial. This trial led to the FDA approval of adjuvant pertuzumab Herceptin. And here patients received surgery, then they got randomized to get either kind of an anthracycline-based program or a non-anthracycline-based program. And they found out that patients that got the pertuzumab and Herceptin did a little bit better. A little bit better. Everybody looked at this and went, oh.
Wow.
All right, now.
So that's people who got the pertuzumab for the full year versus just
The affinity trial, affinity is, you're correct. The patients received both Herceptin and pertuzumab if they were randomized to that, just got them both. And the thing about this particular trial, and you have to realize we put a lot of patients on this trial in our practice, is that in the beginning they were letting everybody in, except the real bitty tiny. They even, if you were young and had a highly undifferentiated HER2 positive, ER negative, they were letting patients with T1Bs in. So they had a lot of very early patients that were not even included in the primary trial. None of the patients on this trial had inflammatory or locally advanced breast cancer. So what happened? The first three, when they first started this trial, I mean, we had patients who were waiting for the trial to open. Boom! Everybody put every patient they had. And then after about 3,600 patients, Genentech, which was running the trial, said, no, we've got to get more high-risk patients on this. You know, we're not going to be able to draw any conclusion. So they stopped putting the lower-risk patients, and the last 1,200 were put in, you know, right before the trial was closed. And so what we're seeing very early on are all these low-risk patients. Well, the low-risk patients do pretty good. Remember what I told you, remember when we went back to the older trials, that the 3-year relapse was about 12%? What do you see here? Even in the control arm. So what are we dealing with? We're probably dealing with a very favorable subgroup. And are these curves going like this, rising? Yes. And what they pointed out was the high-risk patients, the no positive, the ERPR negative, they were getting absolute benefits between 2 and 3%. Yeah, it doesn't sound like a lot, but guys, keep in mind that adjuvant therapy has progressed with 2% here, 3% here, 2% here, to the point these things add up as we go along. So I think it's important to keep in mind this trial will be updated apparently this year's ASCO in June. And then the 10-year data, of course, will not be out until 23. So we still have a long ways to go. But I'm going to tell you, yes, they did use a year. And when the FDA approved the affinity, the adjuvant, they also suggested that the patients of high risk should get a year of pertuzumab and Herceptin, even if they got neoadjuvant. Now, there was a lot of debate among breast oncologists about this, but I think, though, that most of them, once they've had a chance to look at this and recognize that we have a very good group that were, presented at this was presented about a year ago. So I think, though, that you're going to see more about the affinity trial, but there's other drugs coming along, and there's other things that we're doing now in patients that are HER2 positive who get neoadjuvant therapy. We never, for all of our high-risk patients, all of them, at least usually in Texas Oncology and the breast physicians that I know, almost all of us are still doing neoadjuvant for high risk. Okay, so who should get adjuvant pertuzumab? If you take the overall population of HER2 positive, the benefit is small, but you're going to reserve it for the high risk patients, in particular, node positive, hormone receptor negative, perhaps younger people, people that are the PR negative, HER2 positive. So I think that's really important, is that just because you have HER2 positive breast cancer doesn't mean you should automatically get Herceptin pertuzumab. You may want it, but do you really want it? And there is added toxicity, a little bit cardiac, it's there, and diarrhea.
Oh yeah.
All right, what if you have a little tiny tumor? Yes, ma'am.
Sorry, do you mind just adding a little bit to the cardiac risk?
There are two types of cardiac risk in patients that get chemotherapy. One is the anthracycline, where you actually get damage to the myocardium. Okay? But the second type of cardiac toxicity that you get is Herceptin, or Herceptin-like drugs. All of the anti-HER2 therapy, with maybe the exception of neratinib, have been associated with increased cardiac toxicity. The tyrosine kinases, a little bit less. I personally think that neratinib hasn't just been around long enough. So I tell everybody, if you get into HER2, you got it. So what happens? All of our heart cells, muscle cells, have HER2 on the cell membrane, and that's normal. And they serve as stress relievers. So if you take away that stress reliever and you have a stress, the most common stress, of course, is hypertension, age, it's got to be age, hypertension, diabetics over 50, people with prior heart disease, depends upon what kind of heart disease. Valvular heart disease, arrhythmias doesn't entirely exclude you. Patients that have had anthracyclines, because you already have some damage, especially if the anthracyclines are given over 300 milligrams per meter squared. So in general, the cardiac toxicity in most patients is reversible but it does happen. Can you re-challenge a patient if the echocardiogram or mother-scan turns to normal? Yes, but you're going to be careful. If you're a metastatic patient, you're going to be more liberal, right? But if you're adjuvant, the last thing you want is to have a cardiac death on cardiac cripple. And the echocardiograms, they're becoming more sophisticated about trying to pick out which patients may or may not have a chance of getting this cardiac toxicity. In my practice, I had a woman that developed a hypersensitivity reaction to Herceptin, not using Herceptin, and developed this kind of eosinophilic pneumonia, but also a marked decrease in her ejection fraction. And 10 years later, she's fine. By the way, she's a cardiology nurse, so all these things. And she has pretty much recovered her ejection fraction to more than 50%, but it took a while.
So it's something that you either reconcile when you're done with the treatments?
No, you stop the anti-HER2 therapy. Yeah, and you wait for 3 weeks and then you repeat, and you can wait up to 6 weeks. And if you're doing an adjuvant, in her case, she was adjuvant. I don't want to take any chance. I mean, she was symptomatic. So we had her on steroids and, cardiology help. Maybe they do it after reducing agents, and she actually did very well.
With people who have these side effects and they become metastatic, what do you do? You can't give them Herceptin because of the heart issue.
I had a patient recently died with a ejection fraction of 20%. Can't get HER2 therapy. Her heart's under a stress, so she's been died of cancer, but she's been died of a heart disease. Now, she was a diabetic. She didn't take care of herself. Okay? I'm not blaming her. I'm blaming the fact that she had other diseases along with this. I will also tell you she had very extensive disease in the chest. So there are lots of extenuating circumstances, but no, we could not use anti-HER2 therapy. So yeah, there are instances where you just can't do it. If it's borderline, 40, 45, your cardiologist holds your hand. You make sure that that patient is getting their mother scans or their echoes usually on a regular basis. Have I done it? Absolutely. In the metastatic setting, yeah, you've got to treat. And then remember what I just said, the tyrosine kinase inhibitors, in particular neratinib, may have less cardiac toxicity.
But you don't think maybe it's too new to tell that they're neratinib?
I assume they all potentially do. Okay. Do I think that it's likely? No. Am I going to check a baseline? And I'm going to warn a patient about heart failure and maybe even repeat. During the ExoNet trial, which we're going to talk about with neratinib, we did regular echocardiograms in those patients.
Should oncologists be requesting echocardiograms with patients who are doing neratinib, or?
Well, the answer is probably yes. But remember, they've also finished all their adjuvant trial, and they may have had Adria, and they may have had pertuzumab Herceptin. And even though we think it's all reversible, people will sometimes 6 months, 12 months later recheck. So the answer is, yeah, when in doubt. Okay? Why take chances? We're doing adjuvant therapy. All right. Okay, so what if you have a little bitty tiny HER2? Let me just kind of go through this a little bit. These are 2 trials. Now, let me tell you, I can also put up 2 trials that didn't agree with them. But, and these are all retrospective, and most of these patients are really T1Bs. So a T1C is anything less than 5 millimeters. In situ cancer, really tiny tumors. Okay, now the problem comes, is that you can have multi-areas of in situ cancer. So I can't go into this in detail, but the whole point is that small tumors probably have a worse prognosis if they're HER2 positive. So you may in fact want to give them HER2 therapy, and the approach has been to be not quite as aggressive because the trials have shown just giving Herceptin and let's say taxane or Taxol by itself or paclitaxel, but you can get very similar to results, long-term survival for patients that are HER2 negative. Okay. And I think I'll just probably leave it at that. So small cancers don't necessarily require that you throw the whole, gamut at. Okay, what do you do in patients that do not achieve a pathological CR? There are basically a number of trials that show that if you get a pathological CR, you do better, right? The B41 also included triple negative patients. But in general, if you didn't get a pathological CR, you did not do as well as far as disease-free survival. Now, there are people that have questioned this because, again, that's we can talk about it afterwards, but there are people that are like very good breast oncologists that have said, you've got to be careful about using pathological CR. The ER/PR positive patients may not get a pathological CR, and yet they have a very good prognosis anyway. So be careful, talk to your oncologist about this. But the point is that it is true, our goal is to try to get a pathological CR. Neratinib is a pan HER2 inhibitor, a pan tyrosine kinase inhibitor, kind of all the different epidermal growth factors. Its biggest side effects have been diarrhea, significant. This is the Exernet trial that looked at extended therapy. So patients had finished all their treatment, and the higher risk patients then take neratinib for a year, and they found that there was a small advantage for doing that for a year in addition. So you got your year of Herceptin. Remember, this was done before pertuzumab came along. This is a lady Jennifer Homer. And so what they're doing is, when it was published, they found out that most of this advantage was in ER/PR positive patients. However, the FDA approved it for both ER/PR negative and ER/PR positive. So one of the things you could do in a patient who has does not get a pathological CR would be to offer them neratinib, especially if they're hormone positive. And remember, if they're hormone positive, you're going to be doing all the other stuff too, right? So don't forget about that.
And so what if they did have
Say again?
What if they did have a pathological response? What is the status fall in that?
It is usually not used. But and then also remember now, most of our patients are receiving Herceptin and pertuzumab if they're considered relatively high risk. So the answer is I don't have an answer for you, and I wish I did. I find neratinib, you have to be really motivated to want to take 2 or 3 years of treatment. But there are patients, especially if they're really a high risk or ER/PR positive, this is an alternative. Thank you.